So we're going to return to an exciting research presentation now. I'm pleased to introduce our chair of the PSI Grants Committee, Dr. Deborah Cook from McMaster University. Dr. Cook practices critical care medicine at St. Joseph's Healthcare, Hamilton. At McMaster, she is a distinguished professor of medicine, clinical epidemiology and biostatistics, and academic chair of critical care. Her research interests include life support technology, prevention of ICU-acquired complications, end-of-life care, and research ethics. As a Canada Research Chair in Knowledge Translation in Critical Care and former chair of the Canadian Critical Care Trials Group, Dr. Cook has published over 700 peer-reviewed articles and supervised many young trainees and successful faculty. She has received numerous regional, national, and international awards for her practice, teaching, mentoring, and research. In 2016, Dr. Cook became an Officer of the Order of Canada for her global contributions to improving the care of critically ill patients. Please welcome Dr. Cook.
Good morning, everybody. It's a great privilege to speak about some of the work that PSI has funded over the years. I've been privileged to be part of, and I'm not going to speak actually about the work that was seminal in my academic career funded by PSI, but suffice it to say that it was this early start funded by our provincial physician-oriented agency that whetted my appetite for trying to inform and improve the care and the outcomes of critically ill patients. So I think these two words of informing or improving are both important. Not all knowledge generated through research changes practice. And the holy grail of practice changing science is important, but it isn't holy. And sometimes it's just as important to enlighten clinicians and inform the care that we deliver. So with this in mind, I wanted to let you know one of the other reasons that I got involved in PSI, aside from the generous funding of ideas of an early investigator. All of us as social creatures are involved in some societies and groups and communities, whether it is your school, the gym, the colleagues in your department, place of faith. Groups have an organizational culture. And I think of the way personality is to an individual, organizational culture is to a group. And I was struck early on by the open-minded communicative approach of Sam Moore through PSI and learned a little bit more about the organizational culture beyond the mission and the vision that you heard about earlier and that is being aptly refreshed, as Dr. Drover pointed out. So there are a few constructs of organizational culture, how things are around here, the invisible force or forces behind the tangible and observables in any organization, and a social energy that moves people to act. The idea of organizational culture is like a scaffolding to a group and to a research funding organization and much more than PSI represents. It was attributes of the organizational culture that I think are as relevant today as they were 30 years ago when I first became somewhat familiar with PSI. So attributes include hierarchy or lack of hierarchy. Other attributes may include the extent to which establishment or innovation are valued. And there are valences in all organizational cultures. And I was very motivated to become engaged in, but first learn more about the values of innovation, the egalitarian approach as embodied in the mission and vision, things that are visible but also invisible. The other important feature of this funding agency, to me, is that it supports investigator-initiated studies. Enterprises that advance science are often industry-initiated or industry-funded. They may be investigator-initiated and industry-funded. They may be investigator-initiated, industry-partnered with peer review funding. And these are some of the important attributes that I think we need to try to hang on to, because research that has a genesis, shall we say, in practice and is initiated by investigators and funded by peer review agencies is actually the minority of research in the world. So my personal views on investigator-initiated studies are shown here in these, not necessarily the top 10 attributes, but attributes that I think are important for us to remember as touchstones as we move forward in PSI. Studies may be more likely to address some problems facing humanity in general, may be more likely to evaluate widespread drugs, devices, or programs rather than brand new, say, biological agents. The motivation for the market share doesn't exist, even though many investigator-initiated studies have the advantage perhaps of donated drugs or devices to evaluate. There's generally a greater concern for patient and family values and priorities, shared data through individual patient data meta-analyses, especially through the pandemic, as we've all seen with merged databases. Quality improvement may more likely to be at the root. Investigator-initiated studies don't always cost less, but they often do, and they certainly they have fewer charges, or the charges are not conflated, shall we say, with costs. And there's generally, of course, attention to research ethics and preserving researcher independence. Early on, PSI acknowledged the importance of growing the scientists in our province. This is rarely done. Even today, as some of you in the field of critical care will know, in many countries, the same senior investigators do most of the work, lead the work, or are seen to be leading the work. PSI early on was focused on trying to enable early investigators, and I was one of those fortunate individuals. And what I would like to highlight today is some examples. This is the very first project I ever did. It was a photograph taken. People have asked me, when was this? What time was this taken? I can't remember. It was a time when everyone had more hair. And this was a study that was funded by PSI that was physician-led, as is one of our mandates, but was interprofessional. There was a physiotherapist and a nurse involved in this project, and it was the first validating grant that I ever received and was a very important step. I'm going to speak instead about the work led by 3 individuals, early career investigators funded by PSI, with whom I've had the privilege to work, and wanted to give you some examples of what they have discovered and what has informed and what has changed practice. They just happen to be all women, and as Giselle pointed out, we're very keen to more intentionally address EDI within PSI. They happen to be all PhD prepared, and it's great that they have been also interested in critical care. Years ago, technology was introduced into our field with very little evaluation. The value was technology itself. As long as it could do something and give some information, there was often inattention to whether that information brought value or actually generated any wisdom at the bedside. Most research was doctor-driven, was patient-centered to a huge extent, and more recently, there's been interest in evaluating technology in the broadest sense. There's been recognition of the importance of multidisciplinary research because in the intensive care unit, there are a community of professionals that collaborate to try to improve the outcomes of critically ill patients. And family and centered care, patient and family-centered care is really a mantra. So in this sense, and with this backdrop, I wanted to give you an example of some work that Jenny Johnson led. So probiotics are something all of you have eaten, whether you know it or not, and probiotics are found in many different food substances and pills. The WHO has defined probiotics in this unusual, very general sort of way, community available, commercially available microorganisms which, when ingested as an individual strain or in combinations, offer potential health benefits to the host. So it doesn't say what health benefits there will be, and it doesn't speak about a particular drug. So with this generic definition, Jenny Johnson, who is an infectious disease colleague of McMaster, is now in the University of Toronto and has played a major role in the pandemic, trying to keep Ontarians safe and inform, influence the government, was interested in studying this in different settings. So Dr. Deborah spoke about the way we often take information from some settings and try to move that into other settings. So there have been many randomized trials showing that probiotics reduce infection in babies, diarrhea as a condition. Probiotics are used in long-term care facilities very often to try to minimize the risk of infection that may be GI or respiratory related. And there are a host of randomized trials also showing Clostridium Difficile is reduced when patients are getting antibiotics. So Jenny wondered whether or not there would be a role of probiotics in critical illness. Probiotics are a biotic, not an antibiotic. And the concept of being seriously ill is that all of us, we all have a microbiome, a footprint, if you will, an ecological community of organisms in our current health state. Microbiomes for individuals stay more or less static over time, but when people become seriously ill, the so-called healthy microbiome becomes an unhealthy pathobiome as the organisms in us or on us, which is what constitutes the microbiome, becomes modified, whether we're infected or not. And as you know, most infections are addressed by antibiotics, but this construct is that probiotics may actually influence our microbiomes in relatively healthy states. And in critical illness, Dr. Johnson wondered whether there would be a role of the biotic called the probiotic trying to reestablish the healthy microbiome, which itself, like EDI, is characterized by diversity, great microbiome diversity. So she went on in collaboration with many, including the Canadian Critical Care Trials Group, to do a program of research. Dr. Devereux gave you an example of a whole field of perioperative medicine in a series of studies looking to identify, prevent, and effectively treat the complications of surgery. Dr. Johnson had a PhD protocol that she prepared as a pilot study that we implemented, and with others we conducted surveys with largely collaborators in Ontario, systematic reviews. The pilot randomized clinical trial was funded by PSI, a mechanistic sub-study, a number of other sub-studies, and the main randomized clinical trial also co-funded by PSI and CHR and other agencies. This is an example of a program of research, not in an entire field as per the prior example, but within, shall we say, a discipline or a setting, so the discipline of critical care, the setting of the intensive care unit with one intervention of the probiotic, and in fact, one particular type of probiotic. So this main randomized clinical trial was the culmination of this work, but again, it started with PSI. In general, The seriously ill patients enrolled in this 3,000 patient randomized trial were all mechanically ventilated on advanced life support. A lot of them already had infections, and the probiotic we gave was in the yogurt that some of you would have had this morning. One yogurt twice a day down the feeding tube. And the control was usual care with everything else that we do for and with critically ill patients. And we found, in fact, no benefit associated with probiotics for critically ill patients. And Jenny was particularly interested in antibiotic stewardship, being an infectious disease physician, imagining that if probiotics didn't prevent infections if you're critically ill, maybe they minimize the extent to which we use, or shall we say overuse, antibiotics. That was not found to be the case. And in fact, in immune-compromised patients, which characterizes critically ill individuals, there may be harm associated with the increased isolation of the actual bacteria in the yogurt equivalent that's found in the blood of critically ill patients. There were very few events of this sort, and this was even amongst patients with, without any holes in their gut and without any obvious immune-compromised state, because those were excluded. So sometimes information also can be generated and was generated with PSI funding that cautions us about a specific intervention. And Dr. Johnson has done great work beyond this, and we'll hear more from her, I'm sure, again. A different topic is, again, not an organ, not a population, but an event that may seem amusing or perhaps unimportant: diarrhea in critical illness. So diarrhea, as we know, in children can kill infants who don't have access to hydration. Diarrhea can close down a long-term facility and has done so many, many times all over the world. Diarrhea is a problem that is discussed in the intensive care unit by pharmacists who may change medications. Nutritional consultants may often modify the nutrition that we give critically ill patients. Patients having diarrhea who ICU often get their food stopped. They get expensive and frequent tests to find out if their diarrhea is infectious. They have devices shoved in the rectum, which are potentially harmful. And this is a common everyday issue. Joanna Dion, the second young investigator I was mentioning, was interested in this problem in the ICU. She's also a gastroenterologist. And the idea of understanding a little bit more about this common problem is exemplified in the objectives, trying to describe the epidemiology of this problem, the risk factors, the consequences. And she began as an industrious general internal medicine and gastroenterology resident, eventually critical care fellow, to do an international study. But it started in Ontario, funded by PSI, where someone alongside their clinical training was able to work with nurses and pharmacists and dietitians to think about the different definitions of diarrhea and examine their outcomes. And she went on to do an international study recently published, commented and documented on how common it is based on the definition. There's different event rates, the different risk factors for diarrhea, factors that decrease diarrhea, and is going on to try to create other interventions that may mitigate the consequences of diarrhea in the ICU. So this is a different approach of a PSI-funded work, and she too is interested in Clostridium Difficile, which is a very rare but of course very serious problem. And as you may know, within Ontario, C. diff has about a 23-25% recurrence rate as diarrhea that is infectious in etiology. It's very hard to eradicate and is on the rise if acquired when you're critically ill. So another feature of work that PSI funds is linking investigators across different studies. And with databases that we have that are Ontario-based, where sharing is easier, and we don't need to worry so much about interprovincial sharing of data. Dr. Dion went on to identify the incidence of Clostridium difficile and document that Clostridium difficile occurs most often in ICU, and there are a few events after ICU, and this is leading to more cost evaluation and other concerns. There also is an increased risk of death, adjusted, not so clear, but unadjusted, there's an increased risk of death based on the severity. So I think the idea of having data generated within our province that can be shared across investigators is really an exciting feature of PSI-funded work. The last example I'd like to share with you is about end-of-life care, and I'm sure most of you have had someone sick that you love in the pandemic. It's been a tough time. And based on work that a few of us have been involved in the province, we've been trying to minimize the angst people feel when somebody dies in the ICU. And this is one of the projects that has been developed. And the third person I'd like to speak about is Brittany Dennis. And Brittany convinced our group to study the Three Wishes Project in the pandemic. And enrolling patients on the COVID ward, the step-down ward, and in the ICU in the first wave. She interviewed family members of dying patients. The idea of the sacrifice and solidarity that family members demonstrated through the interviews generated these 4 themes. And I'll just show you some of the quotes that were transcribed from her interviews. So an example here of the acquiescence to the restrictions, the limited hospital visiting, and the separation that occurred. Loving and grieving from afar. Early on, there was very little ability, and throughout the pandemic, for family members to be present at the bedside. The ascendancy of virtual visits with technology, which will never leave hospital care from now on. Existential questions posed by family members and respect and appreciation for the clinicians. The impacts, of course, are far beyond the pandemic, and hopefully, as things open up, there'll be more celebrations of life and opportunity to honor those who are no longer here. So all three of these projects were published, and Dr. Dennis has won awards for this work, and it's great. It's great to think about PSI's recognition of what I think of the 2 R's and the 2 F's of what constitutes a project that's likely to move forward, the relevance of it. And I think a lot of people pivoted to study COVID in the last couple of years, and PSI's leadership has been incredible in that regard, with huge number of grants funded. It's got to be rigorous. It's got to be feasible. And it's got to be fundable. This is the core, though, the passion of the investigator. And we always look at PSI for this to come through, the passion that's going to drive these projects to completion. So these 3 individuals are now either on faculty, and in fact, Dr. Dion is on faculty as well, and soon to be Dr. Dennis. And they're just 3 examples of meaningful, informative, practice-informing, and in some ways practice-changing, practice-enlightening work. And it's been a privilege to be involved in this. And thanks to PSI, and on behalf of Brittany, who's here, and Jenny and Joanna, it's been amazing to try to raise the bar and help get over it so Ontarians can live as well and as long and as safely as they can. Thanks.